Hello, everybody, and welcome to our first CBD grand rounds for the new CBD cycle, and this is the SJMC grand rounds number 20. So, if you'd like to stay tuned and not to miss any of our CBD session, please don't forget to like the video, subscribe, and hit the notification bell. So thank you for doing that. If you haven't, just for those of you new to, you're sticking to the same format. Q&A will be at the end of the session, and you can use Slido. Please join us on slido.com. You can scan the QR code, which will take you to the Slido event, or else go to slido.com on your browser or Slido app and add in the code 3477188. Okay, so you can ask questions there, and the panel will answer your questions at the end of the session. And this session is eligible for CBD points, and we'll display the QR code at the end of the session, and you can use the MMA app to scan the QR code to claim your points. So without further ado, I'll pass over to the chair of this session, Dr. Jayamala, and hope you enjoy the presentation. Thank you. I'll go off the camera now.
Thank you very much, Alan, and very good afternoon to all of you. So this will be our 20th Grand Round as SJMC in July celebrates its 37th anniversary. So today we are going to talk about cardiometabolic disorders in pregnancy. As our usual format, it will be case-based. Okay, so I'll start. 37-year-old lady comes for a consult. She had a late marriage and she now plans on getting pregnant. She is worried about the medical disorders of pregnancy considering her age. She's actually quite a healthy person and she's not on any known medications. Her only sister gave birth to twins, and both her parents have hypertension from their 50s. So it gives me great pleasure in introducing Dr. Noraini bin Kasimali, the obstetrician at SJMC, and of course my other partner in crime is Dr. S.P. Chan, who requires no introduction. So Noraini, what general advice would you give to any woman planning to start a family?
Good afternoon, everybody. So in general, women in their reproductive age group are usually young, fit, and healthy. However, having said that, 50% of pregnancies are unintended, unplanned. So ideally, pre-pregnancy counseling should be an integral part of primary health care of women in their reproductive age group. So issues that must be addressed are family planning, how to space pregnancies well and evenly. Number 2, achieving healthy weight, watching the diet as to achieve better pregnancy outcomes. Screen these ladies for infectious diseases and treat them well before they get pregnant. Update all immunizations necessary for a pregnant lady, especially rubella vaccine. Review their current medications and watch for teratogenic effects of the current medications and switch them to appropriate medications. Put them on folic acid. Ideally, it should be 400 to 800 micrograms per day for low-risk moms. Ladies with high risk for neural tube defects should be on 5 milligrams daily throughout the pregnancy. And also control any chronic diseases before they embark into a pregnancy.
All right, thank you very much, Noraini. What about, a lot of our patients, young girls, are obese, they have metabolic syndrome and pre-diabetes, and what is its effect on pregnancy, SP?
Yeah, thank you very much, Jaya. Yes, we do recognize that in Malaysia that there is an increasing prevalence of overweight and obesity, particularly in our young Malaysians, and that includes women in the reproductive age, as Noraidi has mentioned. So that's one, the fact that they themselves are having problems of overweight and obesity. On top of that, unfortunately, they are not necessarily in the best physical condition. We've just come out of MCO, so you can imagine all of them have been very sedentary, so they haven't increased their physical activity. And of course, on top of that, if you have a bad family history of positive first-degree relatives having any of the chronic cardiovascular type illnesses like type 2 diabetes, hypertension, those will also probably increase these women's likelihood of developing gestational diabetes when they are pregnant. So, these are certainly things that we need to address, if possible. As Noraini mentioned, that it should be before they even embark on initiating a family, right? So, Noraini, when you actually see a patient, apart from what you just mentioned to us, are there any biochemical parameters that you actually perform before you say, okay, you can try for a pregnancy?
Yeah, there are some biochemical tests that we can do, mainly to look for diabetes, risk them for hypertension and hypertensive disorders. There are some tests which I will mention later. Even subclinical hypothyroidism should be ruled out before they embark into pregnancy.
Okay, so what happens if a GP finds that the woman has hypertension? Dr. Jaya, what should be the recommendation if they want to become pregnant and they happen to be hypertensive? What would be your recommended drugs, the go-to drugs?
Basically, the RAS blockers, that means the angiotensin converter inhibitors, the ARBs, are thyroidogenic and should be stopped. So the she is pregnant or she misses her period, the advice is she should see her doctor to have it switched to ideally calcium channel blocker or a labetalol or aldomet or one of those safe medications in pregnancy. But in the pre-pregnant stage, I think for young women in the childbearing age, as far as possible, I tend not to use RAS blockers. I tend to use more calcium channel blockers or beta blockers. And if beta blockers, once they become pregnant, I tend to switch to labetalol.
So the point to make is actually that the RAS blocker should not be first choice in young women who are in the reproductive age, just to reduce the possibility of exposure, isn't it, Jaya?
Yes. And you have to, if you really, really need to use it, then you have to warn them about the thyroidogenic potential of these drugs.
Right. What do you think about hypercholesterolemia, Jaya? Does it make any, what do you recommend? What's your advice?
Generally, in women of childbearing age, I tend not to give them pharmacotherapy unless they have got very high cholesterol and they're very high risk of getting a cardiovascular event because everybody in their family has been having or dying of a myocardial infarction young. Then I would consider treating it with a statin, but the moment they become pregnant or think they're pregnant, they should stop.
Those that are very high, I'm sure, are very few and far between. You're talking about perhaps those with familial hypercholesterolemia, homozygote or heterozygote, is that right?
Yes. So in the majority, it's still diet and exercise until they've completed their family.
Okay, we can move along.
Okay, so now what medical disorders do you think she should worry about, Noraini?
Okay. The thing to look at now is her age. She's 37 years old. Women who are in their first pregnancy at 35 and above are categorized as elderly primary gravidas. And elderly primary gravidas are high-risk pregnancies. The incidence, however, is increasing nowadays because either early marriage, late conception, or late marriage and late conception because of rising education levels, better contraceptive practices, higher career goals. So this lady ticks that category and she should be informed of her potential risks. She has an increased risk to preeclampsia and eclampsia. Hyperemesis gravidarum is the most commonest in elderly primates. Gestational diabetes is a risk, premature birth, increased rates for cesarean sections in these ladies, and all the complications that come with cesarean sections. Yeah, that's about the advice I should inform her that she has an increased risk in medical disorders.
Is there anything she can do to reduce her risk?
Yeah, she can try and maintain her weight. If she is of low BMI now, she should try and achieve, ideally that should be the weight that she should be at when she's pregnant. She should watch her diet, try and get a full medical checkup, full gynecological workup, so as to sort out all if she has fibroids, adenomyosis, or ovarian cysts, all that should be settled before she even tries to get pregnant or get into a pregnancy even. She should then also be advised to lead a healthy lifestyle, abstain from cigarettes, smoking, drugs, all those other alcohol even, and excessive caffeine, and she should change lifestyle before trying to get pregnant because of her increased age, advanced age.
Can you show the next slide?
Okay, so these are identifying the mother at risk from the Training Manual Hypertensive Disorders in Pregnancy from an MOH, 3rd edition 2018. I think you can get it out of the net. Okay, so moving on. She gets pregnant and she comes to you with a period of amenorrhea, 7 weeks. Weight is 55 kilos and her heart rate and blood pressure is as shown. At this stage, what test, if any, would you order and what advice would you give her?
It's already very good that she's at a doctor's clinic at 7 weeks. So the thing to note now is a normal BMI, so she's considered at 7 weeks she's at good BMI. So only basic antenatal tests should be conducted at this point, which should include her blood group and her rhesus status, all the infectious diseases. Thyroid control test should be done to rule out subclinical hypothyroidism. Because her BMI is good, I would exclude the HbA1c at this time. Expanding on this, at her 12th week, which is late first trimester, she should have a first trimester screen to exclude congenital abnormalities, which also can nowadays include an early onset preeclampsia test, which consists of maternal serum PAPP-A and a placental growth factor level that can give us a 75% detection rate for preeclampsia in this lady. So if she is high risk, she should be managed appropriately at this stage, so it's 12 weeks onwards, 7 to 12 weeks.
So you advise something that you do, Noraini?
Yeah, if she is, this particular lady, she is at risk because she's 37 years old and she has Most parents hypertensive.
Yeah.
And also she should need to watch her weight very, very closely because if she gains weight, she's going to develop high blood pressure. And then...
Okay, so I assume she has done all the blood tests that you have advised her, and she comes in at 16 weeks, and that is her weight. Is this acceptable?
That's not acceptable. That's too much of a weight gain. That's about 10 kg in just above 2 months, which is way beyond the normal weight gain. And so she should try and cut down, warn her of the consequences of miscarriage, preeclampsia, eclampsia, premature deliveries, gestational diabetes, other obstetric complications. She should watch her diet, eat small, frequent meals, consciously lessen her sugar and carbohydrate intake, and exercise regularly. That would be my advice at this stage, because she's about to get preeclampsia, she's not careful.
Okay, so she comes in at 22 weeks. So the weight gain is a bit less now, but something else happened. Her blood pressure is now 145/96, 140/100, 145/98. So what's the threshold for hypertension in pregnancy, and at what threshold will you start pharmacotherapy, and what target are you aiming for, Naraini?
Okay, at 22 weeks to have high blood pressure is already very alarming for me. And so the definition of high blood pressure in pregnancy is systolic of 140 and above, diastolic of 90 and above. Severe high blood pressure is systolic 160 and above, diastolic of 110 and above. So she's already hypertensive, and we should put her on medication now to prevent the high blood pressure, to prevent uncontrolled high blood pressure in this pregnancy. And I would start her on labetalol 100 milligrams BD to achieve a target of anything below 140 over 90.
Okay, all right. So this from the same book telling you some of the drugs which can be used in these patients. Okay, as Naraini had suggested, she was started on Trenbate 100 milligrams twice a day at 22 weeks. She came 2 weeks later. Her heart rate came down, blood pressure came down to 140/90, urine dipstick negative. Are you happy, Narain?
At the moment, I'm assuming I'm okay with this blood pressure at this dose, because I'm quite sure by now she would have changed her lifestyle. She would be taking leave from work, decreasing her stress level, managing her sleep, controlling her diet, and hopefully she's complying with her labetalol twice a day. So I'm happy.
Okay, so 1 week later she comes, and now the BP is 130/80 on Trend 800 BD. Is there a lower level of BP that you feel is safe, or at what level would you say, I think we must cut down the dose?
A systolic of between 120 to 130 is safe. Diastolic of between 70 to 80 is safe. If she tends to drop more, maybe then cut down. But at the moment, 130/80 is fine with 100 twice a day.
So less than 120 or diastolic less than 70, you would start cutting down. All right. Okay. So what advice are you going to tell the mother? What should you be watching out for?
Yeah. First and foremost, she needs to learn how to do self-BP monitoring at home. Teach her what is the upper limit of normal and what is the lower limit of normal. Also tell her what the impending signs, impending eclamptic signs. Things like hands and feet and face edema. Epigastric pain associated with vomiting is impending eclampsia. Headache and blurring of vision is also a sign to look out for. So any of those, she needs to bring herself to the hospital immediately.
So this is from the handbook, as Naraini has just mentioned. Okay, so she comes in 28 weeks. Now the urine dipstick is 1+. What is the significance of this, and what would you do, Naraini?
Okay, proteinuria is one indication of preeclampsia, which means she is now confirmed preeclampsia, and she should be admitted for close preeclampsia monitoring. Then there should be some bloods run for to look out for liver dysfunction, renal disease, uric acid level to predict the severity of the disease, maybe even coagulation profile if necessary.
Okay, so what is there advice for the mother? You said you're going to admit her already, yeah?
Yeah, and so she needs also to know the risk of preeclampsia, what she's going to face soon, because there's going to be imminent delivery soon, so all that advice has to come around this time now. Talking about premature delivery.
Now, the urine dipstick was 1+, and the BP is 130/90 at 2800 BD. Are you happy to leave it like this, or?
Yes. So I wanted to mention that also her blood pressure meds have to go up. It's 100 PBS, and if it's still not being controlled, she needs to go. We will increase it to 200 twice a day.
So, you know, a lot of these patients are started on aspirin and things like that. So what is the role of these antiplatelet agents, and when should you actually start it?
All right, low dose aspirin has been shown in multiple studies that it prevents and delays onset of preeclampsia. It has to be started in the late first trimester, especially in people who you have assessed risk to be moderate or severe for preeclampsia. It's mandatory to start, in fact, if you've already assessed risk. It's usually initiated between 12 to 28, preferably before 16 weeks to get optimal control. It should be considered in all moms, ladies, no matter what age group, that have been risked as moderate to severe risk for preeclampsia. The normal dose we use is between 75 to 100, depends on which preparation you have in your hospital. And it's given 75 to 100 milligrams daily throughout the pregnancy, and stop just before, about a week before delivery.
So retrospectively, can I just recheck with you, Nuraini? That means she should really have been started on aspirin.
This lady was
further back.
Yeah, at 12.
Okay. Right.
Okay, so now she's at 30 weeks, and the urine protein is increasing. BP also going up. They have increased the trending to 200 BD. What is significance of the worsening urine proteinuria, and what would you now advise?
Okay, urine proteinuria is a direct indication of worsening preeclampsia process and end organ effects. So this patient needs to be advised that 25% out of early onset preeclampsia, like her, will develop severe high blood pressure in that pregnancy and will end up with premature delivery and subsequent complications. BP medication will be increased for this pregnancy as to achieve ideal blood pressure, and that there is very high chance that she is going to be, the delivery is very imminent if it's deteriorating. The blood pressure is deteriorating.
Okay, the weight increase. You know, first you scolded her, then after that you find the BP is like that. I'm sorry, her weight is like that. Is this weight increase acceptable?
It's actually static. There's no increase, and so that could mean that there is fetal growth restriction already. But typically, intrauterine fetal growth restriction is defined ultrasonography, but not by mom's weight. But yeah, it's very likely that she's already having fetal growth restriction at this point in time, which is not surprising because there's placental insufficiency now.
Do you use renal function, creatinine, urea to help guide management as well, Nuraini?
It doesn't predict the process, uric acid has been shown to, the level of the uric acid has been shown to predict the potential deterioration.
The liver parameters?
Yeah, the liver parameters. I mean, if the liver enzymes are raised, and this thing called HELP syndrome, yeah, that's like already the end stage of preeclampsia. So delivery is like very, very imminent.
So in a patient like this, what would you think will be the normal timing and mode of delivery?
Management is usually expectant to achieve fetal maturity at the aim. And preeclampsia is the cause of about 15% of premature births. So ideally, our main aim in managing this lady is to delay her delivery as much as possible to achieve as mature as possible. And so if delivery happens preterm, it's cesarean section, but vaginal trial or vaginal delivery is possible if we can achieve fetal maturity.
Okay, so would you like to say something? You have left some.
Yeah. So the main messages that we put forward here is at booking, it needs to be very early in pregnancy, and you have to assess every lady, no matter old or young, for the risk of preeclampsia at the start. If you find that she's moderate or severe risk, she has to be managed appropriately at that point. And antihypertensives have to be a bit more aggressive as to prevent deterioration of condition, keeping the systolic all the time below 40 and 90.
So are there any long-term sequelae of preeclampsia?
The main sequelae in preeclampsia, ladies, is her next pregnancy. She's at an 8-fold increased chance of getting preeclampsia again in her next. She, however, is a graded risk. If she has developed her first baby early onset before 28 weeks, her chance of getting preeclampsia in the next pregnancy is about 40%. But if she has gotten her late onset preeclampsia, which is after 36 weeks, then her chance of getting it again in her next pregnancy is only 10%. Usually, the diuresis phase starts about 4 days after delivery. BP drops by 4 weeks, sometimes goes on to 3 months, but there's a small proportion of ladies that remain hypertensive. And so the general population of preeclamptic ladies will have a 2-fold chance of getting ischemic heart diseases in later life. The risk is also graded. If you have mild preeclampsia, your risk is not as high as compared to a lady who had severe preeclampsia, and the risk of IHD is higher in later life. The other risks would be cardiovascular disease, renal disease. Also, they may remain overweight postpartum. They then develop higher lipid levels. They get insulin resistance, and they become hypertensive in later life.
Usually, how long do you need to give antihypertensives postpartum? So can you stop it immediately?
The BP classically, a preeclampsia will drop immediately as soon as the baby comes out. So you will not even need antihypertensives in the immediate postpartum.
Okay. All right. Thank you very much, Noraini, for that. We shall move to the next cardiometabolic condition, gestational diabetes. Okay, second case. 44-year-old Malay lady, co-managed by Dr. Noraini and SP Chan, not myself. G2P1, last childbirth 2010, had gestational diabetes then, controlled by diet. She has subfertility. Father has type 2 diabetes. Now she comes in, expected data at 31 weeks gestation. Don't know what happens to the 30 weeks before that. But in January 2022, HbA1c is 5.6%. The oral GTD, which was done at 9 weeks, was normal. At 22 weeks, the fasting was 4.7, and the 2 hours is 8.5. Sorry, 8.4. So yes, SP, what did you do?
All right, she's actually a very, very elderly, not primate, but you can see that she's 44 years old. And Noraini had been trying very hard to manage her. After the dietitian had seen her, she went home, did self-blood glucose monitoring, which is includes, if I can have the next slide. So she was taking, she works. So you can see from the dietary history that despite the dietitian's efforts, she was taking large amounts of carbohydrates in every single meal, except for the dinner, when she goes home and eats her meals. So you can see she takes a plate of fried mee goreng or nasi goreng for breakfast. She eats out near her office, one bowl of white rice. And so despite all efforts, Noraini was tearing her hair out. She was getting fasting glucose of 4 to 5, which is acceptable. But the 2-hour postprandial glucoses were running at 8 to 9. You look on the right side, it actually tells you how heavy she is, and she's in the obese category. At the moment, blood pressure is still normal. Okay, so moving along, this is what I did for her. I don't know whether you can see it. I think you probably can. For me, it's quite small. So there are several aspects of her pregnancy that we need to at least inform the GPs. This is what we do. This is how you can explain and advise a patient. This is what the physician will do. This is what the obstetrician will do, so that you can actually help advise these individuals in their journey of their pregnancy. One is to know what are the glucose targets. In pregnancy, the glucose targets are different. How do we manage it? The answer is you initiate with diet, like what she did with her pregnancy 12 years ago. And then I think Noraini will mention the anticipated, estimated, acceptable maternal weight gain and obstetrical management. So if you can see, she's actually been very helpful. This is from her. And you can see that after seeing me, I initiated her on insulin because I felt that despite the fact that her diet was suboptimal, we don't have the option of having time to go home and try some more. I don't think, because the baby is growing as you speak. All right. So she was initiated on NovoRapid rapid acting because just to address the prandial glucose that was increasing, right? And you can see, despite starting at 6 units 3 times a day, post breakfast and post lunch, you see a whole bunch of red marks above the target. While post-dinner, she's not so much a problem because she's eating at home. Jaya, can I have the next slide? So the first answer, what targets are expected? Before, when waking up, before meals is less than 5.3. 1 hour less than 7.8, 2 hours less than 6.7. Those of you who are managing non-pregnant individuals, whether they are men or non-pregnant women, will realize these are very, very tight targets. And this is what is recommended for women who are pregnant and throughout the entire pregnancy. So recognize this. This is from all the clinical practice guidelines, including the Malaysian guideline. So the next slide will show you very quickly the subsequent weeks that she was escalated from 3 times a day to, again, you can see here, just to recognize that you don't have to give exactly the same units for every single meal. That means you don't have to go 888, 999. It depends on what their carbohydrate intake, and then you teach the patient. If you take a slightly heavier breakfast, like if you take nasi goreng, you take 9 units. If you take like a sandwich, then you take 8 units, like that. So this is what she did, and you can see on the right side of the slide, the next week, she's starting to get towards better numbers. Okay, if I have the next slide, you can see again much better numbers that we are starting to see. One thing to mention, that the numbers of NovoRapid that I am giving her, you can see that it is by no means large. So she's not very insulin resistant, so there's no necessity to consider giving metformin or something to improve insulin sensitivity, right? And if I can just bring your attention to the right side, which has the fasting glucose, you can start seeing that the fasting glucose is starting to go above target. And so she was started on Levemir, the intermediate acting basal insulin at bedtime in order to address the fasting level. So she's moving along the glucose continuum, getting more insulin resistant as the pregnancy gets bigger, as the baby gets bigger. Pregnancy placental hormones leak back into the maternal circulation and increases in insulin resistance. The insulin dose increase goes along with the pregnancy, and then it flattens out around about 36 weeks. Now I'll pass the floor to Doraini and ask about her obstetrical management of this individual. Next slide. Yeah.
Next slide. So then, in this lady, ideally she should be managed by an endocrinologist, of course, because dietary management has failed. And so, at the time when I decided to refer, her fetal weight is still good. It's still corresponding to this. There's maybe a slightly increased glycol volume, which is still not polyhydramnios. So hopefully after referral and getting her sugars to good control, she will remain appropriate for age. I mean, the fetal size should be appropriate for age, and we can avoid polyhydramnios in this pregnancy.
Do you want to explain the FL and FAC first?
FL is femur length, FAC is fetal abdominal circumference, and that's just to measure whether the fetus is growing accordingly or not.
But these are the parameters specifically in hyperglycemia and gestational diabetes that you're focused on, isn't it?
Right.
Okay.
And so, maternal weight. The amount of maternal weight gain is directly affects the immediate and also the future well-being of both mom and baby. So generally in the first trimester, all moms don't put on weight. They even lose some weight, but any weight loss that's more than 5% of her initial weight is abnormal. Especially this is usually seen in hyperemesis gravidarum severe cases. But middle trimester, second and third trimester, the weight gains in underweight and normal weight ladies should be around 0.5 kg per week, about 2 kg per month. So when they are visiting us monthly, we should see a 2 kg, nothing more. That's why the pre-eclamptic lady just now, that 10 kg was excessive. And when you are overweight or obese already at the start of pregnancy, your weight gain should be less. It's about 1 kg per month. That's ideal. Excessive weight gain is an important criteria because it gives us a balance to avoid large gestational age babies, small gestational age babies, preterm labors, obstetric complications, and all the other consequences of complications. Having said that, if you don't conform to the normal weight gain, there are no evidences out there to show that you have to advise a lady to increase weight just to get a good fetal outcome.
So what are the teaching points for gestational diabetes? SP Chan first.
Yeah, the diet should be appropriate for fetal growth. This is not the time to lose weight. However, there is sufficient data to suggest that you can actually restrict caloric estimates for patients, but don't make them starve. Don't allow them to become ketotic. Okay, this for sure. Don't become ketogenic crazy. All right. Cell blood glucose monitoring is essential. In fact, that's now moving towards continuous glucose monitors. Those little Libre monitors that you put behind the arm. That seems to be now the way to go forward with really good real-time glucose monitoring. Know the targets in terms of the glucose that you need to address, knowing that now that it is a lot more ideal. Insulin is the preferred choice because the way that the insulin kinetics are very quick and you can actually adjust it very quickly. Metformin is not that often given unless they're very insulin resistant. But Noraini also plays a very important role, and she needs to, we do collaboration in terms of, what are your aspects, Noraini?
So, obstetric-wise, mainstay is to educate this lady that the importance of effectively managing a metabolic problem. She needs to know what is good diet and how to exercise and get her sugars to be, that's the mainstay of management. Also, we need to monitor fetal growth to make sure that there's good oxygenation of the fetus by doing frequent measurement, fetal parameters measurement, frequent lipovolume measurement, umbilical artery Dopplers, fetal heart monitoring with CTGs. And because there is a high risk for obstructed labor, abnormal lives and all that, we need to know that babies or infants born to women with diabetes are at twofold increased chance of serious birth injuries, threefold cesarean section rate, quadruple-fold NICU care. So these are all things that we have to watch out for. And anytime there is any potential compromise of fetal complication or potential obstetric complication, delivery must take place. Obviously, ideally, it should be at fetal maturity stage.
I think there is a lot less push nowadays for preterm delivery, isn't it, Noraini?
Yes,
because as long as the glucose control is assured, then we can be fairly confident that the mother can carry the baby to term, right? Okay. With that, I'm going to take over Jaya, because I am very, looking at the time. So the next 15 minutes, perhaps we should talk about thyroid disorders in pregnancy. Next slide, please. I'll take over, Jaya. This is a 35-year-old woman that was referred by the obstetrician. She presented with severe vomiting, and by definition, the obstetrician, maybe Noraini can talk about what is the definition of hyperemesis gravidarum. So she was, as usual, admitted because of the severity, and you can see from the physical examination that she was dehydrated, she was tachycardic, and because the obstetrician saw a small goiter and is aware of some of these problems that can coincide with the hyperemesis, a thyroid function was done. So at that point in time, the T4 comes back elevated, TSH comes back suppressed, free T3 is borderline elevated. So when we are asked to see, there's always this query by the obstetrician, am I dealing with a undiagnosed thyrotoxic individual who happens to be pregnant as well? Okay, so if I can go to the next slide, the next slide will show you what are the other historical data and parameters that we look for in endocrinology. So on the right-hand top box is look for past history of thyroidal illness, any family history of thyroidal illness, and it doesn't have to be hyperthyroidism. If you can have another family member having a goiter, then this individual may also have a hypothyroid. They don't all have to have the exactly same thing. She does not have any symptoms of hyperthyroidism, even though there's a little bit of overlap in terms of, the patient is pregnant and she is a little bit anxious because of the pregnancy. So, Noraini, can I ask, how would you manage this woman if she, and what are the how do you decide the clinical status that requires an admission? What is the definition of severe hyperemesis?
Hyperemesis gravidarum itself is a state of nausea, vomiting, in pregnancy. But severe hyperemesis is when there's absolutely no oral intake and she's ketotic, as in there's urine ketones. So that requires admission because ketones are harmful to the fetus. And she may be already imbalanced electrolyte-wise. Her liver enzymes may already be raised, so all this needs to be checked out while managing. So, yeah, immediate management is rehydration, correct electrolyte imbalance if there is, manage her dietary problems, maybe even side consult some of them because they have really bad issues sometimes with social support and all that. Then maybe if you have to start antiemetics and even with very severe, sometimes IV corticosteroids are necessary.
So you rehydrate, you correct electrolyte imbalance, you may need antiemetics, and you might even use steroids if necessary, right? Okay, so the immediate question that I'm asked as an endocrine consult is, does she require appropriate antithyroid? So if I have my next slide, we did not give her any antithyroid because she had nothing apart from a small goiter. She didn't have any thyroid eye disease. She did not have any symptomatology suggesting that she had hyperthyroidism. And so I monitored her. She got better. She got discharged. And you can see in this table here, 8 weeks, 12 weeks, 16 weeks, and you will recognize that the T4 is starting to drop towards normal. By 16 weeks, all her parameters are essentially normal. So this is what we would consider as the transient gestational hyperthyroidism. Are there any specific antenatal issues apart from this hyperthyroid state that we see?
Yes. If severe hyperemesis goes on for more than 12 weeks, you can get very significant weight loss, which will lead to fetal growth retardation, SJMC, premature delivery, and even preeclampsia. Middle trimester, she might develop preeclampsia. Late trimester, she might even get VTE, venous thromboembolism, because of the hypercoagulability state. And these ladies are at risk to higher C-section rates. It's very severe. It's severe until 16 weeks. Usually it normalizes because nausea vomiting is proportionate to the level of beta-HCG, and beta-HCG peaks at about 10 to 12 weeks, drops by 16 weeks, so they should recover by 16 weeks.
So hyperemesis usually lasts how long, Mana?
It peaks at 10 to 12 weeks, should drop by about 16 weeks.
Okay, right. Can I have the last slide? This is teaching points for this particular case. Recognize that in early trimester, the HCG has the same molecular structure as TSH, and so it stimulates the TSH receptors and increases the thyroid hormonal secretion. But again, after careful history, usually there's no necessity to initiate any antithyroid. So the teaching point is we do not need to give antithyroid. It will settle, it will resolve, and the key is actually symptomatic treatment of the hyperemesis. Okay? I'm surprised that a skinny lady like her will get preeclampsia already.
Yeah, if the hyperemesis drags on to 16 weeks, it will predispose her to preeclampsia because of placental insufficiency, nutritional deficiencies.
Okay, right. Last patient that we have prepared for you is again a fairly common scenario. I will try and go through it fairly quickly. Known Graves' thyrotoxicosis, 2015. She has got what we call TSH receptor antibody positive. This puts her in the category of autoimmune Graves' thyrotoxicosis. She relapses whenever she stops her antithyroid, and she actually was having some fertility and informed me at some stage that she was going to go for IUI. At that point in time, she was on, I had already switched her from carbimazole to propyl thiouracil 50 twice a day. And you can see from her clinical status that her thyroid is not enlarged. She has a bit of proptosis, but the thyroid function itself is actually reasonable, with a normal T4 and a TSH that is slightly suppressed, but not terribly suppressed. So at that time, she told me, look, I'm going to have IUI on such and such a date. So what I did was I asked her to omit her antithyroid therapy prior to the IUI attempt. So at the last menses, stop her antithyroid. So the question that she asked me is it safer to stop my antithyroid medication, especially when I'm starting a pregnancy? Will the hyperthyroidism be dangerous for the pregnancy? And why is it necessary to even think about omitting these antithyroid therapy? So if I can just show you the next slide, the answer is these are the parameters that tell us that we can try to omit, okay? But don't worry, this is not something that I expect you guys to talk about. But certainly you can say, look, I think you can see an endocrinologist. They may be able to try and decide with you whether you can omit your thyroid medication. So the next slide is the safety of leaving the hyperthyroidism untreated in pregnancy. If I can have the next slide. So just to show you the next slide is if you are untreated, meaning the patient is florid hyperthyroidism, okay, and the patient accidentally becomes pregnant, the risk of miscarriage is 21%, risk of preterm delivery is almost 90%, pre-eclampsia is 11%, heart failure is 63%. So the risk to the mother and child is significant. So do not allow an uncontrolled hyperthyroid patient to get pregnant. Okay, if they are controlled with antithyroid therapy, you can see on the left hand of that slide. Yikes, not yet. The risk of miscarriage and all the other parameters that I told you was increased drops. Okay, so they need to be controlled, and they need to be controlled with antithyroid and at as low a dose as you can. Next slide, please. Yeah. Okay, the key question is that of late, not really very recent, has been clearly established, unfortunately, that methimazole, which is the same as carbimazole, is associated with embryopathy, teratogenicity. And you can see some of the more common gastrointestinal embryopathy anomalies that are seen. And you can see here in the Danish registry that non-exposed, you see a 0.07 risk of congenital anomaly, while it jumps to about almost 2% if the patient is exposed to carbimazole. And PTU is kind of in between. So that's the reason why if you really need to start a patient while on antithyroid and allow her to get pregnant, PTU is the recognized, accepted alternative. Okay? Next slide shows you when is the highest risk for teratogenicity, and that's 6th to 10th week of gestation. Okay, so that's the time that you want to try. Okay, if I can, don't give any antithyroid, but if you need to, PTU. Okay, and this is what happened to this individual that I managed. Because of IUI, she got multiple pregnancy. So then during the first 6 weeks, she was doing very well. Wow, very well. I felt so proud of myself. But by 12 weeks, boom, came back. Hyperthyroidism came back. So she was initiated on PTU. At 16 weeks, it is switched to carbimazole when the teratogenicity risk is much lower. But, and then you can see at 21 weeks, I could even stop her antithyroid. When we did the thyroid antibody that was positive before had become negative. This is a typical suppression of pregnancy. And I could stop her antithyroid, but at 31 weeks, she took, Noraini had to look after her.
Okay. She developed preeclampsia mainly because it's a twin pregnancy, and preeclampsia is more common in multifetal pregnancies. But she delivered at 31 weeks because it was uncontrolled blood pressure and proteinuria. Okay.
So, Jay, I'm going to ask you to run through to the last slide so that we can have some time run to the last teaching slide. Okay, that one. So for pregnancy, we try and omit antithyroid drugs prior to pregnancy. Give the lowest dose PTU, the one before. Yeah, and you can try and stop, check the trap to see whether or not. If the trap is positive, we have to warn the pediatrician to look for neonatal thyrotoxicosis. And for Noraini?
So mainstay is always early booking in this high-risk pregnancies. She's high risk because she's already known thyrotoxic before she even embarked into the pregnancy. And mandatory fetal anomaly scan in the second trimester because fetal malformations in thyroid disease is very common. Monitor the fetal parameters to make sure we do not miss small gestational age fetuses. And again, timely delivery, trying our best to reach fetal maturity.
So the final take-home messages Diagnosis of hypertension in pregnancy, the BP is above 140/90 after a period of rest on 2 occasions, or there's a rise in systolic blood pressure of 30 mmHg and or rise in diastolic blood pressure of 50 mmHg. As Dr. Noraini said, in these high-risk patients, start low-dose aspirin early, preferably before the 16th week, and you treat with the appropriate pharmacological agents, trying to maintain a blood pressure below 140/90 but above 120/70. Monitor for complications, assess risk of preeclampsia, and always remember you need to time the mode of delivery, trying as far as possible to make sure the fetus is as mature as possible. Gestational diabetes, you want to say something?
Yeah, I think know the targets, diet, don't starve the patient, allow for fetal growth, insulin is the preferred choice, and Noraini.
And yeah, obstetrical concerns would be to avoid any potential obstetric complications, mainly things like malpresentations, cord collapses because of polyhydramnios, obstructed labor. As much as possible, plan vaginal delivery, but if not possible, cesarean section.
Okay, for thyroid, we've just shown you gestational transient thyroid toxicosis. Just observe the patient, thyroid toxicosis. I've just gone through with you. So with that, we'll pass the floor back to Alan.
Thank you all. So there are a couple of questions in the video comments. So I'm sure the first one is both by Hashasha. Can you see?
Cannot see. With short-acting insulin, what would be the risk to control the sugar so strict? Good question. We use analogs because analogs have been proven to give us the best control of glucose. There's very little risk of causing hypoglycemia. Pregnancy state, we allow the glucose goes even lower than usual. In fact, 3.5 is normal for pregnant women. So the risk of low sugars are minimal. If you monitor the patient, we haven't had patients who have had major problems with hypoglycemia. The risk is much, much higher if you allow the hyperglycemia to continue, and you get a fetal macrosomia, and you get intrauterine death if you don't control the glucose in the late stages of pregnancy. So if you are not comfortable, don't worry, we are, all right?
That's another question from the same viewer.
Good question. The person has asked the question, what about the molar pregnancy versus multiple pregnancy versus hyperthyroidism? I think you are talking about the transient hyperthyroidism of gestation. Yes, it is well recognized. These are the risk factors for with transient hyperthyroidism, okay? The multiple pregnancies. We also know that molar pregnancies can very occasionally cause increase in exactly the same because of the HCG being so high. But I hope the molar pregnancy cannot be mistaken lah. You know, the minute the obstetrician puts the ultrasound probe there, you can see whether you see a baby fetal heart or you see grapes. Right?
Yeah, but the question is, what is the thyroid function cut-off for this type of cancer? Is there
I don't know. In fact, no. I think you're okay. Back to the T4, T3, TSH will look very similar. Okay, the T4 will be highest, T3 will be slightly high, TSH will be suppressed. But then you go back to history and examination. You look for the autoimmune process. If you don't see it, then you can be fairly confident that you are dealing with the transient hyperthyroidism. Okay, there's no cutoff point. If the patient is thyroid toxic, then the T3, one of the small subtle signs, the T3 is a lot higher, whereas in the transient ones, T3 is borderline high.
I think there were no other questions in Slido. I've just checked also there are no questions, so I will share the
Thank you very much, everybody. Thanks a lot, SP and Narayani, for joining us. And of course, we have to thank Ellen and Eva. And now we are looking for the most important, the QR code.
Okay, use the MMA app to claim your points, and let's see, first point for 2022. Okay.
23.
I mean, 1st of July this year until 30th of June 2023 is the new CBD cycle. Okay, I think this is already how many years we've gone through, and by now everyone should know you need at least 20 points. So stick with us. Please don't forget to subscribe to our channel, because we are bringing more and more grand rounds to you guys. Each one, it's not just for the point, but hopefully you enjoy the educational content. Yeah. Did it work for everybody?
Yeah, it says you have to get 30 points this year. 30.
Oh, is it? Oh my God.
Where?
Yeah. It says 30. Oi, when did it get changed?
No, needed 19. How come you only got 30?
No, 20.
1 of 30.
No, it's still, I think it's still 20 points.
19. Mine says 19 more to go.
It's okay.
Thanks a lot,
That may be a glitch.
Oh yeah. Okay, now got.
Okay, so thanks everybody for watching, and don't forget to please like the video, because it will help the video be more popular amongst viewers, and people will discover it. And if you please kindly hit the subscribe button to our channel, that will help us grow. Okay, doesn't cost you anything. And wish you all a happy weekend, and see you again in the next grand rounds. And any educational talks from SJMC, we will be happy to try to screen, and so that it will share such educational content with you all guys as much as possible. Okay, happy weekend. Bye-bye.
Bye-bye.